Jumping into chapter 3. All right, we're going to talk about rational drug selection. Our objectives are there. The process of the rational drug prescribing. Okay, we have to define the patient's problem, specify the therapeutic objective, choose the treatment, educate the patient, and then monitor for effectiveness. So when we start by defining the patient's problem, it is very clear it is important that we be clear that we have identified the correct problem. So you guys are going to move on now into health assessment, and then you go into decision making and management. And that is when you're going to learn how to put together all of these factors. You're going to be able to assess the patient and start to develop a working differential diagnosis. You'll be able to figure out how to use the diagnostic testing to confirm your diagnosis, and then figure out how to determine the drugs that are going to be effective in treating that disorder, and that will lead you to develop your plan of care. When we say specify the therapeutic objective, okay, it's just like anything. You have to be pretty clear on what it is you're trying to do. Is your goal to cure the disease? Is it even curable? Are you trying to relieve the symptoms? Is this a long-term plan? Is it palliative in nature? Anytime that you're going to prescribe something, why are you doing it? And this sounds really simple, but oftentimes in practice it actually is not. It sometimes is like, I need to stop and think, what am I trying to achieve here? And so it is important to consider this, that you really, at the end of all of that decision making, you really can understand why you're doing and what your goal is. And then, of course, have you included the patient in your shared decision making? Okay. Again, we talked about that previously, horse to water. It doesn't do us any good if we don't have a shared decision-making process with the patient and have their buy-in for them to even take the medicine we're talking about. Okay. We are lucky in today's modern era that we have evidence-based guidelines pretty much at our fingertips with technology and the internet. The art of it comes, though, is that we have to still individualize it for each patient, and we have to take into consideration all of their unique attributes. We have to consider the pharmacokinetics and the pharmacodynamics of the drug. How does the drug work on our body, and what is our body going to do to the drug? Is it cost effective? Those kind of things. It says in here that the novice providers use analytical, systematic decision making. I don't really think that that's a novice thing necessarily, because we all still do that. But nonetheless, that's what they're talking about here. Experienced providers use experience and pattern recognition, but we still have a process that we use. Part of choosing the treatment then is examining the drug, the dose, the schedule, the duration, the effectiveness, and the safety. They give us a little mnemonic here, the I can prescribe. So indication, contraindications, precautions, cost or compliance, efficacy, adverse effects, and dose, duration, direction. When you are starting the treatment, you are going to write the prescription, including the drug, the dose, and the schedule accurately. You're going to have to figure out, can the patient pay for the drug? Do they have insurance? Do they not? Is it available generic? And then work with your pharmacy to get the prescription filled. Education of the patient cannot be undermined. Poor adherence contributes to worsening disease, hospital admissions, and death. Again, we talked about you're pretty safe if you gear your patient education to the 5th or 6th grade level. In your education, you have to include the purpose of the medicine and what we expect to get out of it, how they are going to take it, and what are the potential adverse drug reactions and what to expect. When you're monitoring for effectiveness of the drugs, you can look at passive monitoring. Is the patient educated on expected outcomes? Do they know when to call you? And then active monitoring is like they need follow-up labs or something like that to make adjustments to the dosing. Okay, remember, we have to know what the drug is going to do to our body and what our body is going to do to the drug. And we have to understand then both of those processes to make sure we're going to get the right effect we're looking for. Safety, cost, patient factors, your provider factors. Okay, so pharmacodynamic factors. The ease of titration influenced by the dose-response curve of the drug. We look at the therapeutic index. If a drug is narrow therapeutic index, it's much more difficult to manage and more dangerous. A wider therapeutic index is always going to be more preferred. And then what is our body going to do to the drug? How is that patient going to absorb, distribute, metabolize, excrete? Those things. Okay, the evidence for therapeutic impact. This is interesting things to think about when we're talking about therapeutic factors. We can have things to help us guide whether or not it's going to be therapeutic through our randomized clinical trials, clinical practice guidelines, or systematic reviews. Randomized clinical trials, you have to pay attention to them and use them with caution. Okay. The hard part about the RCTs is that they tend to use healthier study subjects. So if they're looking for a drug to see how it's going to affect diabetes, they probably are going to want more healthy, quote-unquote, diabetic patients, maybe in their 50s. They probably didn't enlist morbidly obese 84-year-old diabetic patients with also severe congestive heart failure and severe chronic kidney disease. And so if your number of subjects in a randomized controlled trial aren't necessarily always reflective of the general population or of the population you are using the drugs for, we have to take that into consideration. Remember, when you're looking at an RCT, you need numbers needed to treat and numbers needed to harm, and understanding how that works. That is comparing the absolute risk of the medication versus the effectiveness, right? So you got to consider those things too. The safety profile of a drug should be taken into consideration and then weighted against the other factors when you're trying to find the drug that you want to prescribe. Safety, again, can vary with your population. A drug may be safe in a healthy older adult, but also may be a teratogenic, geez, I cannot say that word, teratogen. So it would be unsafe for a pregnant woman. Safety may also vary with the disease process. Some drugs pose safety concerns in patients with liver or kidney disease. Contraindications to a drug in a specific patient population could eliminate it from one of the drugs you can use, right? People may have an allergy to that drug. That kind of takes it out of the running. The U.S. FDA, the Food and Drug Administration, collects information in the post-marketing surveillance phase, and they have it on MedWatch reports. The FDA has a tiered system of safety announcements to promote the drug safety. Okay? So the FDA can issue a public health advisory when the drug's safety information needs to be conveyed to patients or caregivers. When new drug information affects safe prescribing, the FDA could also issue a letter to healthcare professionals, which is an information sheet to provide specifics about that drug. If the drug is considered or determined to have serious safety issues, including serious injury and death, oftentimes it'll get a black box warning. Something you would hear me say all the time if I was ever your preceptor is that if you are ever prescribing a drug with a black box warning, even if you are totally justified in using that drug, you need to make sure you document and that you actually do discuss with the patient or the surrogate that this is a black box drug. This is what it says. I need you to know that. This is why I'm using it, and this is why I think it's the appropriate drug to use in your situation, and document that you had that conversation with them. If you don't and they have a bad outcome, you're going to be up a creek without a paddle. So, a good rule of thumb. Obviously, we have to consider the cost. If they can't afford the drug, they're not going to get the drug. There are lots of drug coupons now. Some of the drug companies are wanting that drug to be used, so that they're giving coupons and prescription savers cards, and you have to go on the website and enroll. There could be a lot of different cost savers to your patients. Sometimes I have called around to pharmacies or called around here and there to figure out how I could get this patient this drug and whether or not they could afford it. The cost to society is also something when you think not just about the actual financial quote unquote cost, but also like when we talk about antibiotic stewardship and all of those things, having really thoughtful prescribing is going to save lives and money down the road. So what are some of the patient factors that will come into play in what we prescribe and why? Okay. Previous adverse drug reactions or previous bad experiences, okay? If you had a patient that once had amoxicillin and didn't know you should take it with food and just got horribly sick on it, and then 10 years go by and you try to prescribe them amoxicillin again, they may actually have a coup in the doctor's office and say, heck no, I'm not taking it again. And so you may have to spend a lot of time convincing them that if they would just do it a little differently this time, as an example. If they've heard of somebody that took that drug, oh no, my neighbor Betsy took that and she had such bad diarrhea she couldn't hardly stand it. There's no way I'm taking that drug. You can come across that as well. Health beliefs come into play. Of course, if they have a spiritual or religious or cultural objective to the drug as well, they're not going to take it. Drug interactions. Oh my gosh. This is a double-edged sword. It's like the bane of my existence working in a hospital, but yet it's a critically important thing. Polypharmacy is such a problem, and drug-to-drug interactions are really important. We have so many drugs available to us as prescribers on the market, there is no way any of us can memorize which drugs can be taken with what. So one of the first things that you have to think about is, could there be a drug-to-drug interaction? And when you're taking care of older adults that are acutely ill, they have 3, 5, 12, 18 medicines that they're taking. And so yes, you're like, oh, I found the perfect drug to give. And then you're like, crap, I can't give it because they're on X, Y, and Z. Your clinical PharmDs are going to be your best friends. They're very helpful in these because they understand these drug interactions. You also may get warned and alerted to death from the electronic medical record dinging every time you order anything. And so this is a problem because you do get, as a prescriber, some alarm fatigue, and you get so tired of every time you do it, 3 boxes pop up, and some of them are just very not specific to your patient. Like, you'll get a ding because one time 7 days ago when they were in the hospital, they took 1 Tums, and now you've ordered some drug, doxycycline, and you'll get ding, 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 don't give it while taking Tums. And you're like, they're not on Tums anymore. And it just gets really annoying and frustrating. And so you really have to train yourself to stop, take a breath, and remember that those systems are in place not to give you a migraine, but to help prevent drug-to-drug interactions. There are some that you just have to decide, okay, well, I need this drug, right? You may see things that say, a few patients taking this, 10% of patients taking this developed X, Y, and Z, right? And so then you're kind of like, well, it's the benefit outweighs the risk. Those kind of situations can happen. Patients' ages matter, obviously, especially if they're young, adolescent, or child age, or if they're adult and they're elderly. Some of the drugs we do have, like Eliquis, have different dosing instructions based on age. And then obviously pregnancy. There are a safe list of medicines that we can give in pregnancy, and if it's anything outside of that, I have no problem contacting an OB on call and asking for advice in pregnant patients. Okay, it can be really challenging. In early stages of pregnancy, first trimester especially, that is when a lot of damage can be done, especially if any of the drugs obviously are teratogenic. The problem is that with pregnancy, we don't want to study things because you would never want to harm a child. So it's really hard to get randomized controlled trials in pregnancy. The FDA will assign a category to pregnant people, C, D, or X. And then in 2014, they changed those categories on drug labels to reflect risks, considerations, and data from previous exposure registries. So there's a lot of things you have to keep in mind when you're working with a pregnant patient. So provider factors. These are things of ease of prescribing or monitoring. Maybe the best drug by the clinical practice guidelines is a drug that requires frequent lab work and drug monitoring. And these are farmers that live in rural Wyoming, and they are not coming back 3 hours 3 times a week to check a drug level. And so sometimes you as the provider, you have to say, I don't have the ability to monitor this closely. I need to go a different route. Formularies are a big thing. The healthcare system that you work with, we or could potentially significantly determine what drug you give. If a drug is non-formulary, it may take 3 days to get delivered. It may be cost prohibitive. You may have a committee at the hospital that has to clear it before they would even order it. There are a lot of things that may be on a formulary or part of a formulary issue that just ultimately don't let you prescribe off-label or off-formulary drugs. You will develop a personal formulary, which is key. When I would speak to older physicians that I've worked with through the years, and I would say, how do you, and that everybody had a personal formulary. You just memorize the top 2 or 3 drugs of each category, and those were your go-to. You were familiar with them. You knew how to use them. You had the physician desk reference, the big old, 40-inch book, because you didn't have up-to-date on a personal cell phone in your pocket. Still, even with up-to-date on our cell phone in our pocket, you will develop a personal formulary, your go-to drugs that you know well, you can dose well, and you can educate well because you just know them in and out. It is also something that happens across different regions. I've gone from one state to another, and I'm like, what the heck? Nobody here prescribes this medicine that I used to use all the time. And people are looking at me like, why would you use that? It's just a cultural thing in terms of region to region. If you are practicing in North Carolina and then you go to Washington State, for example, you may feel like you've entered a totally different environment because things are just done differently. Not wrong, but the culture is different, the nuances are different, and maybe the drug formularies are different. What can influence us to make good prescribing choices? Okay, pharmacopromotion can be a thing. If you work in certain areas, we tend to be a little more isolated inpatient in the hospital from farm reps. But if you are anywhere in some kind of outpatient clinic, oh my gosh, farm reps are tenacious people that are trying to do their job to get to you to promote their drug. And so sometimes you start using the drug that you are given and promoted. This happens in outpatient. When I was doing outpatient cardiology, if I had patients that had low income or poverty stricken, I would give the drugs that we would use that I had a 90-day sample in the office. So yes, that pharmaceutical promotion swayed me into picking that drug because that's what I had available. The other thing we have to remember is that things are always changing. So changes in prescribing recommendations. We have to learn and educate ourselves and learn how we can educate our patients on these new drugs as well. So in summary, the process of rational drug prescribing There's a lot of different things that are at play here. We have to understand the drug factors that are going to influence our drug selection and recognize influences on our rational prescribing like we've talked about here. All right, knowledge check. This is a short chapter. Which of the following are drug factors that influence drug selection? E. Pharmacodynamics, the study of the biochemical and physiological effects of the drug on the body. The pharmacodynamics of a drug must be specific and selective to target the tissues affected by the disease to have the greatest therapeutic effect with the least severe adverse effects. Which of the following is a step in the systematic process of rational drug prescribing? D. The steps of the process of rational drugs prescribing include defining the patient's problem, specifying the objective, choosing the treatment, educating the patient, and monitoring for effectiveness. Very short and sweet, Chapter 3.